So we are on week 7. We just had our second exam. The grades were 76 to 96. It doesn't get any better than that. And mostly we were 80s and into the 90s. So good job, guys. Excellent job. In fact, looking at it very quickly, I don't see any question that was not written correctly. So I think what grades are here is what's going to stick. So I'm actually pleased with that. I like an exam that's solid. This week, you do have a discussion question and you do have a case study. So make sure you get them done. I know that the sim charts take a little time. I know that they're confusing. And you know it's the quiz that gives you your score, but you've got to go through and see and put in all the information where you need to do it. And that gives you all your answers. So I know it's new. I know it's not everybody likes it, but actually, if you do it properly, it's actually a really, really good tool to use. So tonight, we're going to be doing our hematology, immunological dysfunction, and we're going to do, excuse me, I'm wrong. That was last week. I'm going to do cerebral and endocrine dysfunction. Oh my goodness. Yes, I'm tired too. I've got a massive migraine, so I'm trying to work through it for you all tonight. So let's go ahead. Let's do our Kahoots. I did just redo the Kahoots. I was trying to make it better for you all, going through, making sure all concepts are covered. And there are some 4 or 5 different questions that I placed in there. So it is a new one for you all. I'm always trying to renew and revise and make it better for y'all so that you have some really good tools to use to be able to study. Who wants to win tonight? I know you all been studying really hard on the information for tonight. Not. And I know that. So I'm going to try for you to understand it through a Kahoots. And I think I do this one pretty good. I mean, endocrine is a bear and it's diabetes, DKA. Can you imagine? But I'm going to do it in a Kahoots and you will be understanding it by the time I'm done. Anybody else want to join?
I'm trying.
Okie dokie. Make sure you get on camera too, patients.
Oh gosh, I just joined the wrong Zoom.
Patients, make sure that when you're done looking for Kahoot, you get on camera, please. There you go. I don't want you to not get attendance because you're not on camera. All right, we're going to get going. You can listen, okay? You can listen. It's not a problem. So week 7, cerebral and endocrine. Listen to this first question. It's a mind-boggler. Growth hormone is administered by what root? Well, what is growth hormone? Well, you've got 2 lobes in the pituitary gland, and one of them deals with growth. And when we're talking about a kid who's really short, the rest of the family's not. So it's unusual. So they can give them growth hormone up to the point where they stop growing more than 1 inch a year. And many of these children, it is a subcutaneous injection. Can you imagine the commitment that they have to do to say, all right, I want my children to be taller, but it's going to be requiring, just like if you're diabetic, right? We're going to be giving sub-Q injections daily. Highest priority for a patient diagnosed with syndrome of inappropriate anti-diuretic hormone. Let's look at what the words say. Inappropriate anti-diuretic, anti-urinating hormone, too much of that. That's all that means, SIADH. So you have too much diuretic hormone going on. What's going on? Well, you're worried about fluid balance, aren't you? So, when we're talking about fluid, the one thing I want you all to remember is anything, it doesn't matter, fluid, you have to worry about intake, output, and daily weights with children. That will always be one of your answers when you talk about fluid and fluid volume and monitoring it. Which of the following are signs of syndrome of an inappropriate anti-diuretic hormone against urinating hormone and too much of it again? So what are you going to see? So SIADH is all about a child who does not urinate and retains fluid. So how are we going to monitor the therapy that we're giving this child? Well, they're going to have a decreased urine output. So what are we watching? Intake, output, daily weights. Keep remembering that. I'm going to say it again and again tonight. What is important to cover when teaching the family about prolethiazole? It's actually called PTU. It's for hyperthyroidism. And this is one of the teaching things that we have to give these children. And it causes leukopenia. Leukopenia, decreased white blood cells. You are more apt to get infection, so you're at risk for fever, sore throat. And it's a side effect of the medication. So you can't just assume it's an upper respiratory viral or some infection. You need to tell the doctor, he can determine it. You place on antibiotics or not, depends on, what they decide. A multi. An initial sign of diabetes insipidus. This is the opposite of syndrome of inappropriate antidiuretic hormone. So if one, you're not anti-urinating, this one you're urinating too much. And I want you all to remember, diabetes insipidus has nothing to do with a blood sugar. And I can't tell you how many registered nurses in the triage area on diabetes insipidus, the history of, did a blood sugar, brought the child, put him in the room, and said, oh, and the blood sugar was 102. And I go, why? Why do I need a blood sugar? It has nothing to do with it. This is all about intake, output, daily weights, fluid balance. Now, many of you put polyphagia here, and I'm glad you did. Diabetes insipidus is only fluid. When you want to eat, is because you're hungry. Diabetes mellitus, your body can't digest sugar. So your body keeps saying, you're hungry, I'm hungry, I'm hungry. So you want to eat. So diabetes mellitus is the three P's. I'm hungry because the sugar I eat is not being used. So my body's still saying, you're hungry, hungry. And then, of course, it's the same polyuria, polydipsia. Multi. What are the clinical manifestations of juvenile hypothyroidism? When you talk adults, you talk children, and hypothyroidism, they're the same, except one thing. What's one thing that makes children different with any diagnosis with hormones? It's all about growth, okay? So juvenile diabetes, exactly like adults, but it has to do also monitoring growth on these children. If you don't have a thyroid hormone, and this usually is found at birth through, again, meconium ileus, no stool in the first day or so of birth, they're going to be testing for hypothyroidism. And if they don't catch it at birth, when this child's not getting the growth, not getting the weight that it should, and cognitively, developmentally, they're not meeting milestones, they're going to be testing for thyroid. Now, dry skin, sparse hair, constipation, cold intolerance, all of that, just like adults, it's children, but adults are already grown all the way. So children, it's that decreased growth. A child is a simple febrile seizure. What education would you provide to the parents? So you've got a child who can have a seizure at any time. Remember, febrile seizures are they grow out of eventually, usually by about 6 years old. And what happens is you have no fever, you're 99, and then you're 102. So your brain says, oh my goodness, all of a sudden I got hot, I don't know what to do, and it goes into a seizure. Okay, so now you're teaching a parent all about seizures, and it's all about safety, whether it's turning him to the side, clearing the area, side rails up, maybe oxygen, maybe starting an IV, calling the doctor. I mean, that's, when they're in a hospital, that nothing else happening. But at home, it's all about safety, making sure you turn them to the side, have airway and the area clear. When they're shaking, they're not going to hurt themselves. What type of seizure is it when the body is jerking, foaming at the mouth, and the child is rendered unconscious? This is a child that would be the quote real seizures, right? The one that's going to be a lifelong journey of seizures. And it's called tonic-clonic, okay? Absent seizures when they look at you and stare, or maybe one eye gets a little blinking. That's about all you see with an absent. What notable sign may indicate increased intracranial pressure in an infant? So, infants, you are going to see a bulging fontanelle at rest sitting up quiet. That is absolute what fontanelles. Increase in the cranial pressure, you're going to see it in that fontanelle. It's going to bulge. The one thing that you're going to see is that high-pitched crying, and even scalp veins are going to be distended. That's showing you something's going on. And the cry on a neuro baby is completely different than a normal baby. It's like up a notch. It's like it does it. It's irritating because it's like this high scream, not just a normal baby crying. All of the following increase cranial pressure except what? You're going to be taking care of all sorts of children, adults, that have some problems with their brain with increased pressure. You need to know how to take care of them. You need to know when you cause pressure going up and how to avoid those things. So you're going to make sure that you're not going to overload them with extra fluid. So watching intake and output, very important. That coughing, suctioning, you're not going to promote that as often as usual because it increases that pressure. Suctioning is just going to be rare, only when needed it. And the heart rate does not have any interference with cranial pressure. Although, when you start seeing the pressure getting really big, this child's going to start going bradycardy because it hits the brain stem and hits that central nervous where all of those systems that control your blood pressure and heart rate is going to be squished, and all of a sudden bradycardia. That's dangerous. What findings can alert you to a head injury is getting worse? I worked in an ER the last 10 years of my career, and many times we get sports injuries and they fell down, hit the head, or defenders hit each other, and one was rendered unconscious. Bring him into the ER because they need to be checked. And these children would come in, and they seem to be alert, and all of a sudden you explain things, and they're going to start asking the same thing over and over again. As in, was I safe? Did we win the game? Is my dad coming? But the same thing over and over again. Decreased in orientation, decreasing in LOC, whatever you want to call it. They get very confused. A multi. What does it mean when you see a fixed and dilated pupil after a head injury? Working in a trauma center and working a lot as that primary, nurse for trauma, children would come in, let's say, falling off of second-story balconies, which happened quite a few times, believe it or not. And the first thing the medical care does is go and they look at the pupils. Are they still reactive or are they fixed and dilated? If they're fixed and dilated, it is an emergency. We have to decrease that pressure, or this child's going to become brainstem. And look how quick, in 5 minutes. So where's neurosurgery? Get him here now. Let's do something that's helped this child. What medication may be used for a child with cerebral edema due to a fall? Swelling in the brain, extra fluid in the brain. How are you going to get rid of it? Which of these? So furosemide is good for peripheral edema or pulmonary edema. When you talk about brain, mannitol is the drug of choice. Swelling in the brain, you want to get rid of it quick. And that's how you do it. Febrile seizures usually occur in what kids? You know, my firstborn grandson had febrile seizures, and he only had one. So about 6 months to about 6 years, and they usually grow out of it. Now, febrile seizures, can we prevent them? It's very hard because I mean, it's so quick these temperatures go up. I know my daughter-in-law had a thermometer in her hand at all times. I think these kids had their temperatures taken 28 times a day just to make sure that they're not getting a fever so she can medicate them quick. Childhood hypopituitarism results in which condition? Remember, the pituitary gland has two sides. We have the one with diabetes insipidus and SIADH, fluid. The other side is about growth. So when you're talking about hypopituitarism, this is the side where it's growth problems, and that's pituitary dwarfism. How would you describe precocious puberty? And this could happen in boys or girls. This is something that we do stop, with a medication. Actually, it's called Lupron is the name of it. And it could be boys starting to get a beard and getting hair and, trying to grow up too quick. And can you imagine what other children would say? Girls getting breasts, getting menses too early. We like to stop it, let them come in when it should, because most of all, because of the teasing that goes on with other kids. A multi. What lab values are important to monitor with a child with congenital hypothyroidism? And I'll ask you, if you have a child with congenital hypothyroidism and they're getting medications, how do you know it's working? Because they're growing the way they should. Cognitively, they are developmentally where they should be. You know that thyroid hormone is working. So when we're monitoring it, lab values, T3, T4, TSH is thyroid. Growth are adrenal glands. Growth hormones is the other pituitary gland. Cortisol is the adrenal gland. Cortisol, aldosterone. So you're going to get mixed up with all the different ones. Thyroid, parathyroid, pituitary, adrenal. There's a lot to mix up here. How can you monitor for a child with hypo or hyperthyroidism? How do you monitor them? How do you know that's working, basically? We know it's working because what's the big thing that's the difference with adults? It's all about growth. So they're gaining weight and they're getting taller on the progression that they should. What acid-base alteration would you see in a diabetic child with Kussmaul respirations? Now, the reason why I put this question here is Kussmaul respiration promotes a respiratory alkalosis because diabetic children go into metabolic acidosis. And the body is really cool. It's trying to get where it should be and balance and go in the middle. So Kussmaul respiration is respiratory alkalosis, trying to correct the metabolic acidosis from diabetes, especially DKA. A multi. What would a child with Cushing's syndrome look like? Now, this is an adrenal problem now. This is too many steroids, too much steroids, too long of a time of it. So you have Cushing's and Addison's, too much, too little adrenals. So Cushing syndrome, I actually was pushed into Cushing syndrome when I first was diagnosed with RA. They had me gain about 60 pounds. My face was big and round like a moo face. I didn't get the red ruddy cheeks, but more hair on the chinny chin. Acne can happen. And then your body gets fat and pudgy, right? But your arms and legs are skinny because of muscle wasting, protein problems with too much steroids. So this is Cushing syndrome. What drugs are used for nocturnal enuresis? Now, the reason why I put this question here, because it's the same drug we use for diabetes insipidus. I'm just showing you the correlation. Probably show you again when we get to GU, but I wanted to put it here just to show you a similarity. And it's desmopressin, vasopressin, used to help stop bedtime wetting and also to stop diabetes insipidus when they're in full-blown thirsty urinating. What information will the nurse include when teaching a patient about thyroid replacement therapy? So you got a new kid, we figured out he needs thyroid replacement. What are you going to do? What are you going to teach? Morning, night, empty stomach, full stomach? This is important to know. It should be taken in the morning on an empty stomach, same time every day. And the reason why we do it in the morning is because it gives them sort of like a little boost of energy. It gives them that what they need to keep going. To get it at night, they're going to be awake all night long. So morning, same time, every day. That's what's recommended. A multi. You walk into a room, child's room, fever of 104.6. They're having a seizure. What are you going to do? Walk in a room, your patient's having a seizure. What's your responsibility? And you know, it's airway is always number one, right? Turn them over to the side. Check that bed when they're shaking to make sure there's no toys in that will hurt them. Side rails up, pat them if you can. We never put cold water. It's too much of a shock on them. They will come around, turn them on their side and let them go till till they stop. Autoimmune disease of the thyroid gland. This is usually young, late school age, early adolescent women that get this. And my daughter-in-law actually has Hashimoto's. And this is a problem. She's like a couple different medications that has to regulate it. So it's chronically getting drug levels on this. It is called Hashimoto, autoimmune. You can't take it out. It's, one of those, no surgery can be done. You can only medically manage this one with thyroid hormones. Addison disease, the opposite of Cushing disease. This is also a disease where babies born with Addison disease will have ambiguous genitalia. They don't know if they're a boy or a girl, and we have to assign sex to them. And Addison's disease, they're going to be needing cortisol and aldosterone for life. Okay, so interesting one. This is the opposite of Cushing's. This is an adrenal problem. A multi. A ventricular peritoneal shunt. And that's a ventricle in the brain. So this is something that's put up into the brain. It's a tube that goes from the fourth ventricle, behind the ear, front of the neck, down the front of the chest, into the peritoneal cavity. We use this when somehow your body doesn't drain your cerebral spinal fluid good. Something's happened and you get extra fluid and pressure in your brain, so it stops it. Now, behind the ear, there's a lump with these things. It is a pump, but it's not for nursing. This is only for the neurosurgeon. So we leave that alone. What we do, measure head circumference, abdominal circumference, that's it. These are children that come to the emergency room as they get older and their shunts malfunction. They're with headache and vomiting. Why? Increased pressure in the brain causes headache and vomiting. Once they fix it, they're fine. A common sign of Graves' disease includes blank or protrusion of the eyes. This is hyperthyroidism. It's called exophthalmos, yes. A multi. What are signs of hyperparathyroidism? What's a parathyroid? What does it do? So whenever you see problem, this is a parathyroid works with calcium in the body. Calcium and magnesium both work with what? Muscles contractions, whether it's heart or just regular muscles, okay? If you have too much, you sort of get to the point where you're like tight and you go into paresthesia, you get confused and nausea, vomiting. Hypoparathyroidism, you don't have any muscle strength. So it's too much, too little, either hypo or hyper or hypo. Remember, it's about calcium. Calcium, magnesium have everything to do with muscles. Too much or too little contraction. So what does the parathyroid hormone do? So the parathyroid gland is only worried about calcium levels in the body. That's it. So how do you monitor your parathyroid gland? Calcium. A multi. A hypoparathyroidism has the symptoms of technic muscle contraction and you don't have enough calcium. So now what happens? So you're going to see that muscle weakness. You don't have the calcium to make your muscles work. Again, calcium affects muscles. So muscle weakness, tetany, low calcium levels. Which of the following might be a cause of an adrenal crisis or Addisonian crisis? Well, what does the adrenal gland work with? And when you think of adrenals, you think cortisol and aldosterone, right? Which one here has to do with adrenal, with either one of them? Which one? And it's that abrupt withdrawal from steroids. Why do you think we give Medrol dose packs? We go from big doses down to one. It's to make sure that we go on hard and come off easy so the body don't go into an Addisonian crisis. You cure the crisis by giving steroids. So a cardinal sign of diabetes insipidus. I'm going to ask you again, which one is it? This is a highly, highly misconcept. That's why I stuck in another one of these here. to make sure you're understanding. DI has nothing to do with eating. It has everything to do with fluid. It's polydipsia, polyuria. You're drinking too much and urinating too much. That's it. A multi. Congenital adrenal hypoplasia parent teaching should include, remember, Addisonian crisis or an adrenal hypoplasia, not enough adrenal, hormones. This is what I told you before. Addison's disease, needing what for life? Cortisol and aldosterone for life. The child, we don't know the gender. There's not complete body parts, so they are infertile, okay? And we got to make them. Are they a boy or girl? My career, I've only seen one. And I remember seeing the child had a prominent clitoris, a vagina, and testicles. And then they had to decide what were they going to make that baby. I can't imagine a parent having a child born and everybody says, is it a boy or is it a girl? They don't know. Could you imagine what nursing support we need to give that parent? What causes type 1 diabetes? So type 1 diabetes is because the pancreas, the beta cells in there get destroyed, the body attacks itself, autoimmune, and cannot produce enough insulin. You don't get enough insulin, you cannot digest the sugar that the body's giving you. Signs and symptoms of diabetes mellitus. I'm hungry, I'm urinating, and I'm thirsty, right? Those are your 3 Ps. What statement about a pheochromocytoma is correct? This is an extremely difficult thing to find on a patient. All the symptoms come out with hypertension, tachycardia, chest pain, everybody thinks it's, cardiac. Well, what it is, it's an adrenal gland that produces a catecholamine. Every now and then it squirts out this catecholamine, blood pressure goes up, heart rate goes up, and all of these symptoms occur. So, this is something that's difficult to find. A multi. What action should a nurse implement in the care of a patient with a pheochromocytoma? We're monitoring that when it spews this catecholamine out, this like epinephrine type, we have to monitor that. That's all we do for these children. So if it's an adrenal problem and it's catecholamine, we're worried about blood pressure and we're worried about heart rate, aren't we? Because those are the 2 things that will be affected as this catecholamine or sympathetic type response occurs. Multi. Nursing care of the unconscious child include we all know how to take care of the adult who's unconscious, in the ICU. We know those things. Well, the children are the same. We're going to do those neuro checks. We're going to do the vital signs. We're going to do the INO. I mean, we don't want too much fluid in the brain. We know that. Turn, position, keep them dry. All of those things we're going to do. What might you suspect if a child feels jittery, sweating, and is dizzy? When you read these sort of questions, the key thing that you have to look at is, are they awake or are they comatose? Okay? This question says this child feels. So they're awake. They can tell you that. So what you do for this is probably hypoglycemia. What are you going to do? Well, give them something to drink. Milk, juice, give them something sugar. Give them a teaspoon of honey. I mean, high concentrated sugar, right? If they're at least a year old. Symptoms of DKA. Your pancreas is not producing insulin. Your sugar is not being eaten up. Your body is hungry. So it says, all right, sugar, I can't get you. So what else can I eat? I have proteins and I have fat. So we start eating that stuff. So the blood sugar builds up because it can't eat the sugar. And then you eat proteins and you eat fats, and then you have byproducts. Then you have ketones being spilled in the urine. So you have 4 plus glucose, 4 plus ketones. Your blood sugar, I've seen over 1,000 before. And because your blood sugars are so high, you ooze sugar. You're going to have a fruity breath. It smells like a rotten peach that's been sitting in a Tupperware container for a month in the refrigerator. Take the top off, and that sickening sweet smell, that's DKA. A multi. An adolescent with a BMI above 95 has been urinating a lot. What tests can you anticipate being done on this child? It could be a little bit of anything, couldn't it be? So we're definitely going to do a urinalysis, make sure there's no UTI. It looks like it could be diabetes, right? So let's do hemoglobin A1C. Let's look at the last 2 to 3 months of blood sugars. And of course, if you're urinating a lot, you're getting rid of potassium. Let's do an electrolyte panel. Very good. Diabetic ketoacidosis is caused by, what is that? So what happens with DKA is the body cannot get any sugar digested because there's no insulin, and it goes to the proteins, it goes to the fats to eat it up because they're hungry. They need something, so that's what they go for. And that causes DKA. That produces the ketones, that produces, the high blood sugars because you can't use it. And it also causes that urine overflow with the blood sugar high in that too. A multi. A child's admitted with a blood sugar greater than 600 and large ketones in the urine. What's your priority intervention? You got a kid in DKA. What are you going to do first? What is your priority here? You need to dilute with an IV bolus of normal saline, and you've got to start treating that blood sugar with a regular insulin drip. It's a slow, titrated drip, and we monitor blood sugars and dial it up or dial it out down as we needed. Electrolytes are last. The first thing is get the blood sugar down, normal saline, and get some insulin in them. A diabetic child complains of feeling jittery. Blood sugar is 45. What's the best treatment for this child? Again, this child's complaining. That's telling you they're alert. That's the type of thing you have to look for on exams and for your NCLEX. Complaining, not complaining. So give them a cup of orange juice, give them a cup of milk, give them something. Absolutely. Honey is a good one. Your patient's experienced a head injury. What would most concern you? What here is saying, oh boy, we're in trouble now? Remember, with a head injury, you're always concerned of swelling on the brain. It could be swelling into that pituitary gland and it can decrease your urinary output. That's telling me pressure's getting pretty big in that brain. A multi. How do you detect diabetic ketoacidosis? What would you see? So you have elevated blood sugars, you have ketone, and you have 4 plus glucose. Dehydrated, maybe, maybe not, but you definitely know the blood sugar, the ketone, and the glucose. That is classic DKA. A multi. What would alert you that a child's head injury is deteriorating? So the kid is there, and now they're getting more confused, restless. You can't wake them up, and the headache progresses to get worse. And sometimes even like brain tumors, it's going to wake them up, because it's getting so worse. What is the primary cause of injury associated with submersion? Drowning. What's the one thing that we're worried about that will cause some sort of issue? And it's hypoxia. And the reason is when you drown, water goes into your lung and the lungs become hypoxic. This is an injury that actually you could have bad outcomes up to 3 days later. Any child who goes under and has been out that's drowned, we will keep them in a hospital for 3 days, monitoring their respiratory status because they can collapse and get extremely sick. A child's been diagnosed with bacterial meningitis. What is the nursing priority of care? Priority, bacterial meningitis, antibiotics. Okay? Priority, antibiotics. We've got to take care of what's going on in that brain. To identify whether the cause of meningitis is viral or bacterial, obtain a what? How can you find that out? And you're going to have to do a spinal tap. You need to go into cerebral spinal fluid. You need to find out, you can tell almost immediately. A viral spinal tap will come out with clear or colorless fluid. Bacterial will be a little bit cloudy. That is the white blood cells that are in there. Precautions for bacterial meningitis. You got a kid, bacterial meningitis. Do you have to put him anywhere special? Do you have to do anything? And remember, bacterial meningitis is contagious. You can also get it. And it's called droplet. Okay? Important concept there. It is droplet. Airborne. You got to worry about the rooms. Which medication is used for those with increased intracranial pressure to rapidly reduce that pressure? What medication? How do you decrease intracranial pressure quickly? And it's mannitol. Good. Thank you. You got it. A traumatic brain injury is what? And it's that sudden force. It's like an infant falling off a changing table and the head goes bang on the floor. That is a traumatic brain injury. Another multi. Symptoms of traumatic brain injury in an infant. Kid fell off change table on the floor and cracked his head. What are you going to be looking for? You're going to look at that bulging fontanelle, right? Because now you might have that little bit of pressure building up from the swelling. As I said before, those distended neck vein, scalp veins, and you're going to start to see, because of that swelling, bradycardia. And last question for tonight, multi. Which CSF lab results correlates with bacterial meningitis diagnosis? You know, these are things I always used to follow closely. And when I was in the ER, taking care of these children, because again, the priority is antibiotics, and I wanted to start them now. I wanted to protect me as long as that child and everybody else. So, bacteria loves glucose. So you know something? They eat it up. So your glucose is low. But it says protein, yuck, you're nasty. So it's elevated protein. And that's how I remember it. You're going to have an increased white blood cells, and you shouldn't have any red blood cells unless they nick the capillary as they were doing the procedure. Most of the time they do, but hopefully we don't. Patience. Good job, Patience. Number 2, JK. Number 1, drum roll. Bing. Marilio. Good job. Number 4, JW and Queenie. So I believe we're going to have our exam grades out by Saturday. Let me see if I can get it done Friday, but most likely it's going to be Saturday. As you know, nobody did horrible, so nobody, you don't have to worry, because I've already told you what the spread is here. Just make sure that you get your discussion question, case study done. Anybody who wants to go over the exam afterwards, I don't care if you got a 98 or if you get a 78. Anybody who wants to review anything from the exam, I am more than willing to help you. You all have a great, great night. I'll see you next week back in Miami. Bye.
Thank you.